De Quervain syndrome, also known as de Quervain tenosynovitis or de Quervain's tendinopathy, is a painful condition affecting the tendons on the thumb side of the wrist. It occurs when the tendons around the base of the thumb become irritated or inflamed, leading to pain and swelling, especially when turning the wrist, grasping, or making a fist. Key features: location of pain. Pain is located at the radial thumb side of the wrist, often extending into the thumb or forearm. Inflammation of tendons. The condition affects the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, tendons. Finkelstein test. This is a common clinical test where the thumb is placed inside the fist and the hand is ulnarly deviated, bent towards the little finger. A positive result elicits sharp pain along the tendons. Causes: repetitive hand movements, activities that involve repeated grasping, pinching, or wrist twisting, e.g., using tools, typing, or lifting a child, are common causes. Hormonal changes. It is more common during pregnancy, postpartum, and in individuals with rheumatoid arthritis. Treatment: rest. Avoid activities that aggravate the condition. Splinting. A thumb splint may be used to immobilize the thumb and wrist. Anti-inflammatory medications. Non-steroidal anti-inflammatory drugs, NSAIDs, can help reduce pain and inflammation. Corticosteroid injections. Local steroid injections are often highly effective in relieving symptoms. Physical therapy. Stretching and strengthening exercises for the wrist and thumb can improve function. Surgery. In severe or chronic cases, surgery may be considered to release the affected tendons. Would you like more details on the clinical management or differential diagnosis? Clinical management of de Quervain syndrome. 1. Conservative management. Activity modification. The first line of treatment is typically to avoid repetitive movements of the thumb and wrist that trigger pain. Resting the wrist can significantly reduce symptoms. Splinting. Using a thumb spica splint or brace to immobilize the thumb and wrist can relieve pressure on the tendons, allowing them to heal. NSAIDs. Non-steroidal anti-inflammatory drugs, e.g. ibuprofen, naproxen, can reduce pain and inflammation. Physical therapy, specific exercises to strengthen the muscles around the thumb and wrist, as well as stretching exercises to improve flexibility and range of motion, are often beneficial. Ultrasound therapy may also be used. Steroid injections. If conservative measures fail, a corticosteroid injection directly into the tendon sheath is very effective in reducing inflammation. Studies have shown up to 80% of patients experience symptom relief after 1 or 2 injections. 2. Surgical treatment. Indications for surgery. Surgery is considered when conservative measures, including corticosteroid injections, fail to provide relief after 3 to 6 months. Procedure. The surgery involves releasing the first dorsal compartment's sheath, allowing the tendons more space to move without friction. This relieves the pressure on the APL and EPB tendons. The procedure is usually performed under local anesthesia, and patients typically recover within a few weeks with proper post-surgical rehabilitation. Postoperative care. After surgery, patients may need physical therapy to regain full function and strength of the wrist and thumb. Recovery times are generally quick, but avoiding repetitive strain is essential to prevent recurrence. Differential diagnosis. 1. Intersection syndrome. This condition involves inflammation of the tendons on the back of the wrist, often confused with de Quervain syndrome. However, the pain is more on the forearm, about 4 to 5 centimeters proximal to the wrist, and is typically related to rowing or skiing activities. 2. Osteoarthritis of the thumb, carpometacarpal arthritis. Pain at the base of the thumb, particularly with pinching or gripping, can mimic de Quervain syndrome. X-rays can help in distinguishing between these two conditions, as arthritis will show joint space narrowing or osteophytes. 3. Radial nerve entrapment, Wartenberg syndrome. Compression of the superficial branch of the radial nerve causes pain and numbness on the back of the thumb and hand. Unlike de Quervain's, this is more sensory than inflammatory and usually has a different distribution pattern of pain or tingling. 4. Trigger thumb. A condition that causes the thumb to lock in a bent position due to inflammation in the flexor tendon, leading to pain and difficulty extending the thumb, which can sometimes overlap with symptoms of de Quervain. Additional considerations. Pregnancy. De Quervain syndrome is commonly seen in women during pregnancy and postpartum due to hormonal changes and repetitive lifting of the baby. Management in these cases often includes conservative treatment and steroid injections, as surgical interventions are typically deferred. Rheumatoid arthritis. Rheumatoid patients are at a higher risk of developing tendon sheath inflammation, and de Quervain syndrome may sometimes be associated with systemic joint disease. Is there a specific aspect you would like to explore further, such as more on the physical exam or therapy recommendations? Prevalence of de Quervain syndrome. De Quervain syndrome is relatively common, particularly in adults aged 30 to 50. The condition is more frequently observed in women, with estimates suggesting that it affects women 8 to 10 times more often than men. Some studies report a prevalence rate between 0.5% and 1.3% in the general population. It is especially prevalent in certain occupational groups or individuals engaging in repetitive hand activities, including caregivers and those in manual labor jobs. The syndrome is also commonly reported in new mothers and caregivers due to repetitive lifting of infants. Athletes engaging in sports that involve repetitive wrist and thumb movements, e.g., racket sports, golf. Etiology of de Quervain syndrome. The exact cause of de Quervain syndrome is not always clear, but it is generally believed to result from a combination of mechanical and inflammatory factors leading to stenosing tenosynovitis of the first dorsal compartment. The key pathological mechanism involves overuse and repetitive strain. Repetitive wrist movements or gripping motions cause friction between the tendons, the abductor pollicis longus and extensor pollicis brevis, and their surrounding sheath. This leads to inflammation and narrowing, stenosis, of the compartment, restricting the smooth gliding of the tendons. Inflammation of the synovium. Inflammation of the synovial sheath that surrounds the tendons contributes to pain and swelling. In some cases, microtrauma to the tendons from repetitive activities can also lead to degeneration rather than purely inflammatory changes, especially in chronic cases. Risk factors. Several factors increase the risk of developing de Quervain syndrome. 1. Repetitive hand and wrist activities. Occupations or hobbies that involve repetitive thumb and wrist movements, such as typing, knitting, gardening, or carpentry, are significant risk factors. These repetitive motions put strain on the tendons. Number 2. Pregnancy and postpartum. De Quervain syndrome is common among women during pregnancy and after childbirth, possibly due to hormonal changes and repetitive motions while caring for the baby, lifting, holding. This group is at particular risk, with studies suggesting that it affects 0.5% of postpartum women. 3. Female gender. Women are much more likely to develop this condition than men, with the female-to-male ratio being approximately 8:1. The increased prevalence in women could be linked to anatomical differences in the wrist or hormonal factors. 4. Age. De Quervain syndrome is most common in people aged 30 to 50. Younger individuals, especially new mothers or caregivers, are also susceptible. 5. Rheumatoid arthritis and inflammatory conditions. Inflammatory conditions, particularly rheumatoid arthritis, increase the risk of developing tendon inflammation, including de Quervain syndrome. 6. Direct trauma or injury, a history of trauma to the wrist or repetitive strain injuries, such as those seen in athletes, can predispose individuals to this condition. 7. Underlying anatomical variation. Some individuals may have variations in the anatomy of the first dorsal compartment, such as an extra tendon or septum that predisposes them to stenosis, contributing to the syndrome. Understanding these risk factors helps guide both prevention and treatment, particularly in those groups more vulnerable to the condition, such as postpartum women and people engaged in repetitive hand movements. Would you like further exploration of risk mitigation or preventive measures? Preventive measures for de Quervain syndrome. Prevention of de Quervain syndrome involves minimizing the strain on the wrist and thumb tendons, particularly for those at high risk, such as postpartum women, caregivers, and individuals performing repetitive hand activities. Here are several strategies that can help reduce the risk of developing this condition. 1. Ergonomic adjustments. Modify workplace setup. for individuals who perform repetitive tasks such as typing or manual labor. Ensuring proper ergonomics can prevent excessive strain on the wrist. Adjust the height of the work surface and position tools to maintain a neutral wrist position. Use proper equipment. Use ergonomically designed tools, especially if you work in a profession that involves frequent gripping or twisting motions, e.g., using a screwdriver, gardening tools, or racket sports. This can reduce the force required and the stress on the wrist. Supportive wrist devices, wearing a wrist brace or support while performing repetitive tasks, can help keep the tendons aligned and reduce strain. 2. Posture and activity modification. Maintain proper wrist position. Avoid positions where the wrist is bent or twisted for long periods. When lifting objects, keep the wrist neutral, not bent at an angle, to minimize strain on the thumb tendons. Take frequent breaks. For people whose work involves repetitive movements, regular breaks can relieve pressure on the tendons. Break up tasks involving wrist motions with rest periods or alternate activities. Correct lifting techniques. New mothers or caregivers can be taught to lift their babies using their forearms or with the palms of both hands to distribute the weight evenly, rather than lifting with the thumbs and wrists alone. This can significantly reduce strain on the tendons. 3. Strengthening and stretching exercises. Thumb and wrist stretches. Regular stretching of the wrist, thumb, and forearm muscles can prevent stiffness and improve flexibility, reducing the risk of developing de Quervain syndrome. Simple stretches include bending the wrist gently backward and forward while keeping the arm straight. Strengthening exercises. Strengthening the muscles around the wrist and thumb can improve their ability to handle repetitive tasks. Resistance band exercises, squeezing a softball, or using small weights can help build strength in the wrist and thumb extensors. Avoid sudden increases in activity. Gradually increasing activity levels, especially if starting a new sport or repetitive task, allows the tendons to adapt to the increased load. 4. Lifestyle modifications. Postpartum care. Since new mothers are at higher risk, awareness of this condition and preventive strategies are important. Learning baby carrying techniques that minimize wrist strain, such as cradling the baby closer to the body and using the forearm to support the baby, can help. Avoid overuse. Limiting the duration of activities that require repetitive wrist and thumb movements, such as texting or using handheld devices, can prevent the development of the syndrome. If using a smartphone, holding it with both hands and using other fingers instead of just the thumb can also reduce strain. 5. Early intervention and awareness. Recognize early symptoms. Early signs of de Quervain syndrome include mild discomfort or tenderness on the thumb side of the wrist, especially with certain movements. Addressing symptoms early with rest, ice, and activity modification can prevent progression. Education on risk factors. Educating individuals in high-risk groups, e.g., pregnant women, caregivers, and workers engaged in repetitive manual tasks, about the risks and symptoms of de Quervain syndrome can prompt early preventive action. 6. Splinting and supportive measures. Preventive splinting. For people in high-risk jobs or those who have mild symptoms, using a thumb spica splint intermittently can prevent overuse and minimize strain during repetitive tasks. Ice and anti-inflammatory measures. Applying ice to the wrist after performing high-demand tasks can reduce inflammation and prevent tendon irritation. Taking NSAIDs after particularly strenuous activities may also be helpful in individuals with a predisposition to tendinitis. By adopting these preventive strategies, especially in high-risk populations, individuals can reduce their likelihood of developing de Quervain syndrome or mitigate its severity. Regularly practicing ergonomic principles, performing stretches, and being aware of early signs are crucial for maintaining healthy wrist and thumb function. Would you like to explore specific stretches or exercises that could be useful for prevention? Exercises and stretches to prevent de Quervain syndrome and recurrence. To prevent de Quervain syndrome and its recurrence, strengthening and stretching exercises for the wrist, thumb, and forearm are key. These exercises help maintain tendon flexibility and reduce strain on the tendons. Here's a routine focused on both prevention and recovery that targets the muscles and tendons involved. NAM 1. Wrist stretches. Wrist flexor stretch. Extend one arm straight out in front of you, palm facing up. Use the other hand to gently pull your fingers back toward your body. Hold the stretch for 15 to 30 seconds, then relax. Repeat 3 times on each side. Wrist extensor stretch. Extend one arm with the palm facing down. With the opposite hand, gently press your fingers down and back toward your body. Hold for 15 to 30 seconds and repeat 3 times on each side. These stretches improve flexibility and reduce tightness in the forearm muscles that contribute to tendon overuse. 2. Thumb stretches. Thumb flexor and extensor stretch. Place your hand palm up on a flat surface. Use your other hand to gently pull your thumb across your palm and down toward the base of the pinky finger, flexion. Hold for 15 seconds, then gently stretch the thumb back, extension. Repeat 3 times on each hand. Thumb abduction stretch. Hold your hand out with fingers straight. Gently pull your thumb away from the rest of your fingers using the opposite hand. Hold for 15 to 30 seconds. Repeat 3 times on each hand. 3. Strengthening exercises. Radial deviation strengthening. Hold a lightweight 1 to 2 pounds or a small bottle in one hand with your arm resting on a table, palm facing inward, thumb side up. Slowly raise the weight towards the ceiling by lifting only your thumb and wrist, not your forearm. Lower slowly and repeat for 10 to 15 repetitions. Perform 2 to 3 sets. Thumb isometric exercise. Place your hand palm up on a flat surface with a rubber band around your fingers and thumb. Gently spread your thumb away from the fingers, holding the tension for 5 seconds. Return to the starting position. Repeat 10 to 15 times for 2 to 3 sets. Grip strengthening. Use a soft stress ball or a rolled towel. Squeeze the ball with all fingers and thumb for 5 seconds. Release slowly and repeat 10 times. Perform 2 to 3 sets. These exercises help strengthen the muscles around the thumb and wrist, improving their resilience against repetitive strain. 4. Forearm strengthening. Wrist curls. Sit with your forearm resting on a table or your thigh, holding a light weight with your palm facing up, wrist just off the edge. Slowly curl your wrist upward, then lower it back down. Repeat 10 to 15 times for 2 to 3 sets. Reverse wrist curls. Similar to wrist curls, but with your palm facing down. Slowly lift the wrist upward and lower it back down. Perform 10 to 15 repetitions for 2 to 3 sets. Strengthening the forearm muscles, wrist flexors and extensors, supports the wrist and reduces strain on the tendons involved in de Quervain syndrome. 5. Tendon gliding exercises. Tendon gliding stretch. Extend your fingers straight out. Slowly bend your fingers into a hook fist, then into a full fist, and finally straighten them back out. Repeat 10 to 15 times to improve tendon flexibility. 6. Prayer stretch. Wrist flexor stretch. Position. Start with your palms pressed together in front of your chest, like in a prayer position. Action. Slowly lower your hands, keeping your palms together until you feel a stretch in your forearms and wrists. Hold. Maintain this position for 15 to 30 seconds and repeat 3 times. Prevention of recurrence. 1. Gradual return to activity. After treatment or surgery, avoid jumping back into repetitive activities too quickly. Slowly reintroduce movements that involve the wrist and thumb to prevent re-injury. 2. Continue regular exercises. Keep doing the above strengthening and stretching exercises regularly, even after symptoms have resolved. These exercises help maintain flexibility, strength, and endurance, preventing future recurrences. 3. Modify activity patterns. Avoid prolonged, repetitive wrist and thumb movements, especially those that aggravate symptoms. Break tasks into shorter sessions and take frequent breaks. 4. Ergonomic tools. Continue using ergonomic tools to reduce strain on your hands and wrists. Modify your work setup or daily routine to maintain good wrist posture. 5. Use of thumb spica brace. In high-risk situations, such as during activities that involve repetitive thumb or wrist motions, wearing a thumb brace can help support the thumb and wrist, preventing further strain on the tendons. 6. Self-mush. Massaging the wrist and forearm can improve circulation, reduce muscle tightness, and help prevent tendon stiffness. Use a tennis ball or foam roller to gently massage the area around the thumb and wrist tendons. 7. Avoid overuse. Avoid performing activities that overuse the thumb and wrist for long periods, such as excessive texting, typing, or lifting heavy objects without proper support. By combining these exercises with ergonomic modifications and proper wrist care, you can effectively prevent the recurrence of de Quervain syndrome and maintain wrist and thumb health. Would you like a more detailed guide for specific exercises with images or further information on any particular aspect? Diagnosis of de Quervain syndrome. The diagnosis of de Quervain syndrome is primarily clinical, based on a combination of the patient's history, physical examination, and characteristic symptoms. A key aspect of the diagnosis is identifying the pain associated with the abductor pollicis longus and extensor pollicis brevis (EPB) tendons. Below are the main steps involved in diagnosing de Quervain syndrome. TARB 1. Patient history. Symptom description. Patients typically report pain and tenderness on the radial thumb side of the wrist, especially when making gripping motions, lifting objects, or moving the thumb. Onset of pain. The onset may be gradual or linked to a particular activity, e.g., repetitive motions, lifting a baby. Exacerbating factors. Activities like lifting, grasping, or pinching can worsen the pain. Associated conditions. Inquiring about risk factors such as recent pregnancy, repetitive strain activities, or rheumatoid arthritis can help pinpoint the diagnosis. 2. Physical examination. Tenderness along the radial wrist. Palpation over the first dorsal compartment along the thumb side of the wrist will elicit tenderness. Swelling in this area may also be observed. Crepitus. In some cases, you may feel or hear crepitus, a grinding sensation, as the tendons move within their sheath, especially in severe cases. Thumb range of motion. Pain may be exacerbated when the patient performs thumb movements, particularly thumb extension or abduction. Finkelstein test, key diagnostic maneuver. The Finkelstein test is the hallmark physical examination maneuver used to confirm de Quervain syndrome. It stretches the tendons of the APL and EPB, which are affected in the syndrome. A positive test indicates a high likelihood of the condition. Performing the Finkelstein test. Position of the hand. The patient is asked to make a fist, tucking the thumb inside the fingers. The wrist is then ulnarly deviated, bent toward the little finger side. Action. The examiner gently holds the patient's forearm with one hand and deviates the wrist towards the ulnar side using the other hand. Response. If this maneuver reproduces sharp pain along the radial side of the wrist at the base of the thumb, the test is considered positive. The pain occurs because ulnar deviation stretches the inflamed tendons of the APL and EPB, which pass through the first dorsal compartment. This tension on the inflamed tendons exacerbates the pain, providing a clear indication of de Quervain syndrome. 4. Variations of the Finkelstein test. In some cases, the Eichhoff's test is used, which is a variant of the Finkelstein test. The difference lies in how the hand is positioned. The patient actively flexes the thumb across the palm and wraps the fingers around it, similar to Finkelstein. The wrist is then deviated towards the ulnar side, toward the little finger. Positive Eichhoff's test. Pain along the radial wrist is elicited in the same way as the traditional Finkelstein test. 5. Imaging when needed. While de Quervain syndrome is typically diagnosed clinically, imaging may be used in uncertain cases or to rule out other conditions. Ultrasound. This can reveal thickening or fluid accumulation around the APL and EPB tendons, confirming inflammation. It is a useful, non-invasive tool to visualize tendon pathology. X-rays. Though not commonly required, X-rays can help rule out conditions such as osteoarthritis of the thumb base, carpometacarpal joint, or fractures if there's a history of trauma. MRI. This is rarely needed but can show detailed soft tissue inflammation, thickening of the tendon sheaths, or synovial changes. Differential diagnosis. Based on the Finkelstein test. While the Finkelstein test is highly specific for de Quervain syndrome, it is important to distinguish this condition from other causes of radial wrist pain. 1. Intersection syndrome. Pain in this condition is more proximal, further up the forearm, where the APL and EPB cross over the tendons of the extensor carpi radialis longus and brevis. The Finkelstein test may be negative, but tenderness is localized higher up on the forearm. 2. Carpometacarpal, CMC, joint arthritis. The Finkelstein test may be negative in patients with CMC arthritis. Pain in CMC arthritis is often worsened by pinch grip activities and located at the base of the thumb, but joint grinding, crepitus, and bony changes can usually be felt during a thumb grind test. 3. Wartenberg syndrome. This involves the entrapment of the superficial radial nerve, causing sensory changes, numbness or tingling, along the radial side of the wrist and hand. The Finkelstein test may not reproduce symptoms in these patients, but tapping over the superficial radial nerve can induce paresthesias, Tinel's sign. Sensitivity and specificity of the Finkelstein test. The Finkelstein test is highly specific for de Quervain syndrome, meaning that a positive result strongly suggests the diagnosis. However, it is not always highly sensitive, as some patients with mild cases may not experience severe pain during the test. Therefore, the test should be used in conjunction with the patient's clinical history and other physical findings. In summary, the Finkelstein test remains a reliable and effective method to diagnose de Quervain syndrome, especially when combined with a thorough physical examination and patient history. Would you like more details on how to distinguish this from similar conditions or further insight into imaging studies? Yes, the Finkelstein test can occasionally be positive in normal individuals, especially if the maneuver is performed too forcefully. While the test is highly specific for de Quervain syndrome, it is possible to elicit some discomfort or pain during the test in individuals without the condition, particularly if they have mild tendon tightness or engage in repetitive wrist or thumb activities. However, in normal individuals, any pain experienced during the Finkelstein test is typically much less intense and more generalized than the sharp, localized pain seen in patients with de Quervain syndrome. A true positive Finkelstein test in de Quervain syndrome is characterized by severe, sharp pain along the radial side of the wrist and thumb, pain that closely mimics the patient's typical symptoms, reproduction of pain that the patient experiences during daily activities, such as gripping or lifting. In contrast, a normal individual may experience mild discomfort or stretching sensation, but typically won't have the intense pain that is specific to de Quervain syndrome. Considerations for a positive test in normal individuals. Force applied during the test. Excessive force during the test may lead to pain even in someone without de Quervain syndrome, as the tendons are forcibly stretched. Individual variations. Some individuals may have naturally tighter tendons or reduced flexibility, leading to mild discomfort. Repetitive activities. People who engage in frequent or repetitive use of their thumb and wrist, e.g., texting, typing, might experience mild discomfort even without an actual pathology. Therefore, while a mildly positive Finkelstein test can occur in some normal individuals, it should be interpreted alongside the patient's symptoms and clinical presentation to make an accurate diagnosis of de Quervain syndrome. Would you like to explore other diagnostic tests or further differentiate it from related conditions? To further differentiate de Quervain syndrome from related conditions and refine the diagnosis, it's important to consider other diagnostic tests and clinical evaluations that help rule out or identify similar conditions. Here are some tests and techniques that can be used. 1. Eichhoff's test. This is a variant of the Finkelstein test, but involves active participation from the patient. Procedure. The patient makes a fist, wrapping the fingers over the thumb, and then actively ulnarly deviates the wrist, moves it toward the little finger. Positive result. Reproduction of pain similar to Finkelstein's test. Significance. It is considered less specific than the Finkelstein test, but can still help identify tendon irritation in de Quervain syndrome. 2. Intersection syndrome test. Intersection syndrome is another tendinitis-like condition, but it affects the area higher up the forearm, where the APEL and EPB tendons cross over the extensor carpi radialis longus and brevis tendons. Procedure. Palpate the forearm 4 to 6 centimeters proximal to the wrist on the dorsal side. Ask the patient to extend and flex their wrist actively. Positive result. pain, tenderness, or a grinding sensation over the intersection point of the tendons. Differentiation. Pain is located more proximally than in de Quervain syndrome. 3. Grind test, thumb CMC grind test, used to assess carpometacarpal CMC joint arthritis. Procedure. The examiner grasps the patient's thumb at the metacarpal base and applies an axial load while rotating and grinding the thumb in a circular motion. Positive result: pain, crepitus, grinding, or discomfort at the CMC joint. Differentiation. In CMC arthritis, pain is located at the base of the thumb, where the thumb meets the wrist, which is distinct from the tendon pain in de Quervain syndrome. There may also be visible joint changes or bony swelling in more advanced arthritis. 4. Tennel's sign for Wartenberg syndrome. Wartenberg syndrome involves compression of the superficial radial nerve, which causes sensory disturbances rather than tendon pain. Procedure. Tap along the superficial radial nerve at the wrist, particularly over the radial styloid, the bony prominence near the thumb side of the wrist. Positive result: tingling, numbness, or shooting pain radiating down the radial aspect of the hand. Differentiation. Unlike de Quervain syndrome, Wartenberg syndrome causes numbness or tingling along the radial nerve distribution, not sharp tendon pain. The Finkelstein test will usually not reproduce the patient's symptoms in this case. 5. Ultrasound examination. Ultrasound is a useful non-invasive tool to visualize tendon structure and detect any changes in the tendons of the APL and EPB. Procedure. A high-frequency transducer is placed over the first dorsal compartment. The tendons are examined for swelling, thickening, or fluid accumulation. Positive result: thickening of the tendons, presence of tenosynovitis, fluid in the tendon sheath, or compression within the first dorsal compartment. Differentiation. This can confirm de Quervain syndrome by showing the characteristic inflammation, whereas other conditions like CMC arthritis or Wartenberg syndrome would not show the same findings. Schummer 6. Radiographs. X-rays. X-rays are typically normal in de Quervain syndrome, but can be helpful in ruling out other conditions like fractures or osteoarthritis. Positive findings. In conditions like CMC arthritis, you may see joint space narrowing, bony spurs, or other arthritic changes. Differentiation. While X-rays won't show soft tissue inflammation, tendons, they help exclude bone-related conditions.
Other considerations: MRI, occasionally used when ultrasound results are inconclusive, especially in more complex cases or to rule out other soft tissue injuries. MRI can show tendon inflammation, synovitis, or even small tears in the tendon. By combining the Finkelstein test with these other physical exam maneuver and imaging studies, a clinician can confidently diagnose de Quervain syndrome and differentiate it from other causes of wrist or thumb pain.
Intersection syndrome. Intersection syndrome is a condition that involves inflammation of the tendons in the forearm where the abductor pollicis longus APL and extensor pollicis brevis EPB tendons intersect with the extensor carpi radialis longus ECRL and extensor carpi radialis brevis ECRB tendons. It is sometimes referred to as Orsman's wrist or crossover syndrome because it commonly affects individuals involved in activities requiring repetitive wrist and forearm motions. Anatomy involved. The inflammation occurs in the dorsal back part of the forearm, about 4 to 6 centimeters proximal, closer to the elbow to the wrist joint. The APL and EPB tendons, responsible for thumb movement, cross over the ECRL and ECRB tendons, responsible for wrist extension and radial deviation, at this point, hence the name intersection. Etiology: causes. Intersection syndrome is caused by repetitive wrist and forearm movements that stress the tendons at the point of intersection. The repetitive friction between these tendons can lead to inflammation, swelling, and pain. Common causes include overuse from sports like rowing, skiing, weightlifting, or racket sports. Occupational activities that involve frequent wrist extension and flexion, such as using a screwdriver or hammer. Repetitive strain injuries from everyday tasks like typing, knitting, or other hand-intensive activities. Clinical presentation. Pain. Patients experience pain on the dorsal radial side of the forearm, about 4 to 6 centimeters above the wrist joint, which is distinct from the more distal pain in de Quervain syndrome. The pain may be dull or sharp and often worsens with activity. Swelling. Swelling may be visible or palpable over the point of tendon intersection. Crepitus. A characteristic creaking or grinding sensation. Crepitus may be felt or heard when the tendons move during wrist or finger extension, especially with forearm activities like lifting or gripping. Tenderness. Palpation of the affected area elicits tenderness. Diagnosis. The diagnosis of intersection syndrome is primarily clinical, based on the patient's history and physical examination. Key diagnostic maneuvers include 1. Palpation. Tenderness can be detected by palpating the area where the APL and EPB cross the ECRL and ECRB tendons, about 4 to 6 centimeters proximal to the wrist joint. 2. Crepitus test. The examiner can ask the patient to actively flex and extend their wrist while palpating the dorsal forearm. A gritty, creaking sensation may be felt as the tendons rub against each other. 3. Differentiating from de Quervain syndrome. Pain in intersection syndrome is located higher on the forearm than in de Quervain syndrome, which affects the radial side of the wrist, closer to the thumb. The Finkelstein test will typically be negative in intersection syndrome, as the APL and EPB tendons are irritated where they cross over the ECRL and ECRB tendons, not at the wrist. 4. Imaging studies, when needed. Ultrasound can reveal fluid accumulation or tendon thickening in the area of intersection. MRI may show inflammation or thickening of the tendon sheaths, particularly when distinguishing intersection syndrome from other soft tissue pathologies like tendinitis or tenosynovitis. Differential diagnosis. Intersection syndrome can sometimes be confused with other conditions involving wrist pain. Some key differential diagnoses include de Quervain syndrome. Pain in de Quervain is more distal, near the base of the thumb, while intersection syndrome pain is more proximal, higher up the forearm. Extensor tendinitis. Inflammation of the extensor tendons, not at the intersection, can present similarly but lacks the characteristic crepitus of intersection syndrome. Radial nerve entrapment, Wartenberg syndrome. This causes numbness or tingling along the radial nerve, but does not involve the inflammatory crepitus typical of intersection syndrome. Treatment. Treatment for intersection syndrome is generally conservative and aimed at reducing inflammation and addressing the underlying cause, typically repetitive motions. Treatment options include 1. Rest and activity modification. Avoidance of aggravating activities, such as rowing, lifting, or repetitive wrist extension, is essential to allow the inflammation to subside. Temporarily modify work or recreational activities that involve wrist and forearm strain. 2. Immobilization, splitting. A wrist splint may be used to limit wrist motion and reduce stress on the inflamed tendons. A thumb spica splint is commonly used, similar to the treatment for de Quervain syndrome. Duration. Immobilization is typically recommended for 1 to 3 weeks, depending on the severity of symptoms. 3. Anti-inflammatory medications. NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen or naproxen, can help reduce pain and inflammation. Topical NSAIDs or anti-inflammatory creams may also provide localized relief. 4. Physical therapy. Stretching exercises. Once acute symptoms subside, gentle stretching exercises for the wrist and forearm can help improve flexibility and reduce tension in the affected tendons. Strengthening exercises. Strengthening the muscles of the forearm, wrist, and hand can help prevent future overuse injuries. Ergonomic adjustments. Modifying the patient's workspace or posture to reduce strain on the wrist and forearm during repetitive tasks. 5. Corticosteroid injections. For more severe cases, a corticosteroid injection may be administered into the affected area to reduce inflammation and relieve pain. This is typically reserved for cases that do not respond to conservative measures. 6. Surgical treatment. Surgical intervention is rarely needed, but in chronic or recurrent cases, surgery may be performed to release the tendons and reduce friction at the site of intersection. This is usually only considered after failure of several months of conservative treatment. Prognosis. The prognosis for intersection syndrome is generally good with conservative treatment. Most patients recover fully after a period of rest, immobilization, and rehabilitation exercises. Recurrences can occur if the patient returns too quickly to the activities that originally caused the condition. Prevention. Avoid repetitive strain. If you are prone to wrist or forearm overuse due to sports or occupational activities, it's important to take frequent breaks and avoid repetitive motions. Strengthening and flexibility. Regular forearm and wrist stretching exercises, as well as strengthening programs, can help prevent future episodes by improving tendon resilience. Proper technique, ensuring proper ergonomic technique during activities like lifting, rowing, or typing can reduce the risk of developing this condition. Wartenberg syndrome, superficial radial nerve entrapment. Wartenberg syndrome, also known as superficial radial nerve entrapment, is a condition characterized by compression or irritation of the superficial branch of the radial nerve. It causes sensory disturbances, such as pain, tingling, or numbness along the radial thumb side of the wrist and hand. This condition is different from Wartenberg's sign, which is associated with ulnar nerve dysfunction. Anatomy involved. The superficial radial nerve is a sensory nerve that supplies sensation to the dorsal, back, side of the thumb, index, middle finger, and part of the hand. It travels superficially along the forearm, just under the skin, and becomes more vulnerable to compression as it crosses the distal forearm near the radial styloid. Etiology causes. Wartenberg syndrome can result from various causes that lead to nerve irritation or compression. Common causes include 1. Direct compression, wearing tight wristbands, watches, or handcuffs that compress the nerve. Trauma to the wrist area, such as from a fall or direct blow. 2. Repetitive motion, repetitive forearm pronation, turning the palm downward, and supination, turning the palm upward, can irritate the nerve, especially in activities like using a screwdriver, typing, or texting. 3. Surgical or medical procedures. Surgical interventions around the wrist, such as for de Quervain syndrome or fracture repairs, may lead to superficial radial nerve injury. Needle injections or blood draws that inadvertently affect the nerve. 4. Inflammation. Conditions like tenosynovitis, inflammation of the tendons and their sheaths in nearby areas, can indirectly cause nerve compression. Ganglion cysts or other masses near the radial styloid can compress the nerve. Clinical presentation. Patients with Wartenberg syndrome primarily experience sensory symptoms along the radial aspect of the wrist and hand. The key symptoms include pain, a sharp or burning pain along the radial side of the wrist and hand. The pain may radiate toward the thumb and index finger. Numbness or tingling, sensory disturbances such as numbness, tingling, or paresthesia, pins and needles sensation along the back of the thumb, index, or middle fingers. Hypersensitivity. The skin over the affected area may become overly sensitive to touch or pressure, hyperesthesia or allodynia. Exacerbation with movement. Symptoms may worsen with wrist or forearm movements, particularly pronation and supination, rotational movements. Absence of motor deficits. Since the superficial radial nerve is purely sensory, there is no associated muscle weakness or loss of motor function in the hand or wrist. SHAR diagnosis. Wartenberg syndrome is diagnosed based on the clinical presentation and physical examination. Key diagnostic maneuvers and tests include 1. Tinel's sign. Procedure. The examiner taps lightly over the course of the superficial radial nerve, usually near the radial styloid, thumb side of the wrist. Positive result. Tingling, numbness, or shooting pain radiating along the nerve's distribution, thumb, index, or middle fingers. 2. Finkelstein's test, to rule out de Quervain syndrome. This test may cause some discomfort in Wartenberg syndrome due to nearby structures being irritated, but it generally does not reproduce the patient's specific symptoms of nerve pain. It helps differentiate between de Quervain syndrome, which affects tendons, and Wartenberg syndrome, which affects the nerve. 3. Wrist and forearm maneuvers. Pronation and supination. Symptoms may be worsened by movements that stretch or compress the superficial radial nerve, such as rotating the forearm or flexing the wrist. Sensory testing. Light touch and pinprick tests can reveal areas of reduced or altered sensation along the radial side of the hand and fingers. 4. Ultrasound or MRI, optional. In some cases, ultrasound can help visualize any compression or impingement of the nerve caused by ganglion cysts or other masses. MRI may be useful for ruling out other causes of wrist or hand pain, such as tenosynovitis or tendon issues, but is not routinely required. Differential diagnosis. Wartenberg syndrome can be confused with several other conditions involving the radial side of the wrist. Key conditions to differentiate include De Quervain syndrome involves inflammation of the APL and EPB tendons, causing pain and tenderness on the radial side of the wrist. The Finkelstein test will be positive, and the pain is tendon-related, not nerve-related. Carpal tunnel syndrome affects the median nerve and causes numbness and tingling in the thumb, index, and middle fingers, but typically not the back of the hand or the dorsal thumb. Phelan's and Tannel's signs are positive over the carpal tunnel. Radial tunnel syndrome. Compression of the posterior interosseous nerve, a motor branch of the radial nerve, which can cause deep aching pain in the forearm and weakness of wrist or finger extension. Treatment. Treatment for Wartenberg syndrome is typically conservative and aimed at reducing compression or irritation of the superficial radial nerve. Options include 1. Rest and activity modification. Avoiding repetitive movements or activities that aggravate symptoms, such as frequent pronation and supination of the forearm, is essential. Avoiding tight objects. Removing or loosening wristbands, watches, or other tight accessories that may compress the nerve. Splinting. A wrist splint may be used to immobilize the wrist and forearm in a neutral position, reducing nerve irritation. Splinting is typically recommended for 2 to 3 weeks to allow symptoms to improve. 3. Anti-inflammatory medications. NSAIDs, e.g. ibuprofen or naproxen, can help reduce inflammation around the nerve and provide pain relief. Topical NSAIDs may also be applied to the affected area for more localized relief. 4. Corticosteroid injections. In some cases, a corticosteroid injection around the nerve may help reduce local inflammation and provide temporary relief of symptoms. This is often used if conservative treatment does not sufficiently alleviate symptoms. 5. Physical therapy. Nerve gliding exercises. These exercises help mobilize the superficial radial nerve and reduce the risk of entrapment or compression. Stretching and strengthening. Physical therapy may include stretching exercises for the wrist and forearm muscles to reduce pressure on the nerve and improve function. 6. Surgical intervention. Rare. Surgery is considered in rare, severe cases where conservative treatments fail and the symptoms are disabling. The goal of surgery is to release the nerve from any structures compressing it, such as scar tissue or ganglion cysts. Prognosis. The prognosis for Wartenberg syndrome is generally favorable, with most patients experiencing significant improvement with conservative treatment. Early intervention is key to preventing chronic symptoms, and the majority of cases resolve with rest, splinting, and activity modification. Prevention. Avoid repetitive wrist movements, limiting repetitive pronation and supination activities, e.g., using tools, typing, helps reduce the risk of superficial radial nerve irritation. Use ergonomic tools, modify the work environment, or use ergonomically designed tools that reduce strain on the forearm and wrist. Avoid tight accessories. Ensure that watches, bracelets, or wristbands are not too tight, as these can contribute to nerve compression. CMC joint arthritis is a common condition affecting the base of the thumb where the first metacarpal bone meets the trapezium bone, forming the CMC joint. This joint is essential for thumb movement, including pinching and gripping. Arthritis here is often due to wear and tear of the joint cartilage, resulting in pain, swelling, and loss of function. Prevalence. CMC joint arthritis is particularly common in women over the age of 50. Women are more prone due to increased ligament laxity and smaller joint size. People with osteoarthritis in other joints. Manual laborers, or individuals with hobbies requiring repetitive thumb use, e.g. knitting, gardening. Etiology. Causes. CMC arthritis is primarily a result of osteoarthritis, but may also be caused by trauma or injury. Fractures, dislocations, or repeated sprains of the thumb can predispose the joint to arthritis. Ligament laxity. Some individuals may have naturally looser ligaments, leading to joint instability and early cartilage wear. Rheumatoid arthritis. While less common, inflammatory arthritis can affect the CMC joint as part of a systemic disease process. Risk factors. Age. The risk increases with age as joint cartilage naturally wears down over time. Gender. Women are at higher risk, especially postmenopausal women. Repetitive use. Jobs or activities that involve frequent gripping, pinching, or twisting motions, e.g., hairstylists, musicians, increase the risk. Genetics. A family history of arthritis can increase the likelihood of developing CMC joint arthritis. Previous injury. Prior trauma to the thumb or hand may accelerate the onset of arthritis. Clinical presentation. Patients with CMC joint arthritis often experience the following symptoms. Pain. The most common symptom, especially at the base of the thumb. The pain worsens with activities requiring pinching or gripping, e.g., opening jars, writing. Swelling. Swelling may occur at the base of the thumb, making the joint appear enlarged. Weakness. Reduced grip and pinch strength are common, making daily activities difficult. Stiffness. Joint stiffness, especially in the morning or after periods of inactivity, is common. Deformity. In advanced cases, the thumb may develop a Z deformity, where the metacarpal base becomes prominent, a result of joint subluxation, causing the thumb to appear shortened and bent. Diagnosis. Diagnosis is based on a combination of clinical examination and imaging studies. 1. Physical examination. Grind test. The examiner grasps the thumb and applies axial pressure while rotating the CMC joint. A positive test elicits pain and a grating sensation, indicating cartilage damage. Palpation. Tenderness is typically localized over the CMC joint, and crepitus, a grinding sound, may be felt with movement. 2. Imaging. X-rays can reveal joint space narrowing, subchondral sclerosis, and osteophyte bone spur formation at the CMC joint. Ultrasound or MRI. These are not commonly needed, but may be used in more complex cases to assess soft tissue or ligamentous damage. Differential diagnosis. CMC joint arthritis can be confused with other conditions that cause thumb or hand pain, such as de Quervain syndrome. This involves inflammation of the tendons in the thumb and is typically more localized along the radial thumb side of the wrist. Trigger thumb. This is caused by thickening of the flexor tendon sheath, leading to painful locking or clicking with thumb movement. Scaphoid fracture. A break in the scaphoid bone in the wrist can cause pain at the base of the thumb, though this is more traumatic and acute in onset. Treatment. Treatment for CMC joint arthritis focuses on relieving pain, improving function, and slowing disease progression. Options range from conservative to surgical interventions, depending on the severity. 1. Conservative management, activity modification. Reducing activities that aggravate the joint, such as excessive gripping or pinching, can help alleviate symptoms. Splinting. A thumb spica splint or brace can immobilize the joint, reducing pain and inflammation by limiting thumb movement. This is particularly effective in early stages. NSAIDs, non-steroidal anti-inflammatory drugs, e.g. ibuprofen or naproxen, can reduce pain and swelling. Topical analgesics. Capsaicin or NSAID gels may be applied to the skin over the joint to provide localized pain relief. Steroid injections. Corticosteroid injections into the CMC joint can reduce inflammation and provide temporary relief of pain. These are useful in moderate cases, but are not a long-term solution due to potential side effects with repeated use. Physical therapy. Therapy can focus on strengthening exercises to improve the stability of the joint, range of motion exercises, and joint protection techniques to prevent further wear. 2. Surgical treatment. Surgical options are considered for patients with severe CMC arthritis who fail conservative treatment. Options include trapeziectomy, removal of the trapezium bone, which forms part of the CMC joint. This is a common surgical option and may be combined with a tendon interposition procedure to help stabilize the joint. Ligament reconstruction and tendon interposition, LRTI. After trapeziectomy, a portion of a nearby tendon, usually the flexor carpi radialis, is used to stabilize the thumb by filling the space left by the trapezium. Arthrodesis, joint fusion, involves fusing the bones of the CMC joint to eliminate pain. This procedure reduces motion but preserves strength for gripping. Arthroplasty, a joint replacement surgery where the CMC joint is replaced with an artificial implant. This is less common, but may be considered for specific patients. Prognosis. The prognosis for CMC joint arthritis is generally good, especially with early diagnosis and conservative management. However, as arthritis is a degenerative condition, symptoms may gradually worsen over time if left untreated. Surgical outcomes are typically positive, with most patients regaining function and experiencing significant pain relief. Prevention. While CMC joint arthritis cannot always be prevented, the following strategies can help reduce the risk or slow the progression. Joint protection, using assistive devices, e.g., jar openers, to minimize stress on the thumb joint. Avoid repetitive strain. Modify work or recreational activities that involve repetitive gripping, pinching, or twisting. Maintain hand strength. Strengthening the muscles around the CMC joint help provide better joint stability and reduce strain.